audio for Donna Williams, University of Phoenix, Nursing, Section 468. Topic: Summative Assessment Interprofessional Collaboration. Introduction. The purpose of accreditation is to ensure that recognition is given to institutions that have fully met certain standards of educational quality by an agency or an association. Accreditation is a process by which outside organizations will evaluate healthcare facilities' procedures to make sure that facilities are giving safe and quality care to patients. The Joint Commission was founded in 1951 to enhance the quality of healthcare with the support of other healthcare organizations to the population. The Joint Commission is the largest and oldest accrediting body in the healthcare system. The existence of the Joint Commission has enhanced the quality of healthcare organization, nursing practice, and patient care, among other benefits. The U.S. Health Services. The Joint Commission has a very extensive history that starts in 1910 and spreads to today's date. The report analyzed the history of the Joint Commission, its benefits to healthcare, and the significance of existence and to the different levels of healthcare provisions. Discuss the history of the agency or body. The end result system of hospital standardizations was introduced between 1910 and 1913 and became an American College of Surgeons goal. The minimum standards for hospitals were developed between 1917 and 1918 by the American College of Surgeons and starts making on-site hospital inspections. The first 18-page standard manual is printed in 1926. The Joint Commission for Accreditation of Hospital was established between 1950 and 1951 after the merger of the American College of Physicians, the American Association, the American Medical Association, and the SCS. The JCH under Erwin Crosby as the director started accreditation in 1953 after the ACS transferred its programs for hospital standardization in 1952 to it. The JCAH published its first standards for hospital accreditation between 1953 and 1959 under a new director, Kenneth Babcock. The JCH starts to charge for surveys in the 1964-1965 period under a new director, John D. Porterfield. During the same period, Congress made the JCH accreditation to become a requirement for hospitals to their preparation to participate in medical and Medicare programs through passing of the Social Security Act amendments in 1965. Between 1966 and 1969, the JCH begins the accreditation of long-term care, creates four councils of accreditation to create the standards and procedures for survey accreditation. The Accreditation Council for Psychiatric Facilities were established in 1970 to start the accreditation and survey substance abuse programs, psychiatric facilities, and community mental health programs. Also, the accreditation period for long-term care facilities and hospitals was reduced from 3 to 2 years during the same period. The finding of JCH was to validate by the Secretary of the U.S. Department of Human and Health Services. Starting in 1972 after the amendment of the Social Security Act, also during the same period, the Accreditation Council for Long-Term Care was established, as well as for the publication of the first issue of Perspective on Accreditation. Between 1975 and 1977, the Council for Accreditation of Ambulatory Care is established and started the accreditation of ambulatory health care facilities under John E. Affeldt as the new director. An agreement between the JCAH, the College of American Pathology, in 1978 allowed the recognition of CAP accreditation for laboratories and hospitals that have the JCH accreditation instead of the laboratory accreditation by the Commission. During the same period, the American Dental Association is admitted as a corporate member of the JCH. In addition, each accreditation program was assigned a professional and technical advisory committee in the 1979 to replace the Accreditation Council. The accreditation cycle was reverted to 3 years from 2 years in 1982-1983 for all hospitals and medical facilities under JCH accreditation. During the same period, the Hospice Care of Organization accreditation started and was replaced by the Home Care Accreditation Program in 1990. In 1983, the nonprofit making consultant subsidiary of the JCH was created as Quality Health Resources Incorporated, which was later replaced by the Joint Commission Resource. Also, Dennis S. O'Leary became the new director or president of the commission during the same period. The commission name was changed to the Joint Commission on Accreditation of Healthcare Organizations in the 1987-1989 period to reflect its wider scope. The primary agenda of the name change was to create emphasis on the relationship between accreditation and organization's performance. And then in 2007, the name was shortened to the Joint Commission. In addition, the development of indicators-based performance monitor system begins in 1989. In 1990, the Commission opened its headquarters and conference center in Washington, D.C., and Oak Brook Terrace, Illinois. Between 1992 and 1993, smoking in hospitals were prohibited by a Joint Commission standard to all accredited health organizations. Also, a national government was reported that after unannounced surveys, home health agencies that had been accredited by the Joint Commission met necessary conditions of participation for the Medicare program. In 1994, the Joint Commission released its first organization-specific public report and implemented a news-wide system cross-department orientation surveys process. Also, the Joint Commission International is established after the merger of the Joint Commission and Quality Healthcare Resources Incorporated to educate and offers consultation services to international clients. Explain the reason for existence. The JCAHO was established in Chicago in 1951 and as an independent nonprofit making entity with the primary role of voluntarily accrediting hospitals and other medical entities. The role of the Joint Commission is to analyze and accredit the more than 22,000 healthcare organizations in the U.S. intended to motivate them to achieve the provision of safety and effective care that is of value and quality to the patient. Because of its validation by Congress through passing a federal act, the JCAHO accreditation is a critical stage for healthcare organizations that seeks leisures. In addition, all JCAHO accredited health care organizations qualify for certifications as Center for Medicare, Medicaid, or CMS programs, as they become peers, recognized entities by insurance and other payers. Summarize the agency public reporting of indicators, alcohol and tobacco. The quality reports that the Joint Commission recommends to the public information to people on safety and quality of care. The Joint Commission public reporting of the quality indicators is done quarterly or after every 3 months on its quarterly check website for all the issues. The essence of the Joint Commission public reporting is to sensitize the public as well as inform them of any medical conditions and health issues to encourage a healthy lifestyle in the U.S. It provides value. The latest Joint Commission reporting quality indicators for influenza vaccination was contained in the Arthur Report issue. The main agenda in the report involved achieving 90% influenza vaccination rates for licensed and independent practitioners and staff in critical access hospitals, ambulatory health care, laboratory, behavioral health care, and human services, and home care, laboratory, nursing care centers, and office-based surgery. The Joint Commission has reiterated the importance of compliance with influenza despite not being a ground for scoring non-compliance. Alcohol. The Joint Commission reports that the timely intervention for substance use, especially before addiction, lowers the cost and improves the health of the users and those with addictive disorders. Also, the website reports that there are no tobacco treatment, electrical, clinical quality measures which is applicable or available for accreditation. Tobacco. The Joint Commission reports that there is enough evidence that timely and effective tobacco dependencies interventions lower the exposure of tobacco use and the tobacco-related diseases. In addition, it improves the outcomes for those already suffering from tobacco-related diseases. Also, there are no substance used as ECOMs for accreditation. Current function. The current function of the Joint Commission provides important information relating to patient safety, pain management, infections control, suicide prevention, among others. The Joint Commission implement and develop measures for accountability and quality improvement. It also sets severe, achievable, and reasonable performance expectations for organizations. Most important, it offers accreditations to many healthcare organizations. Governs a 21-member commission board, including educators, consumers advocates, quality experts, employers, nursing administration from the Joint Commission. This is the governing body of the Joint Commission, which offers oversight and policy leadership. In addition, it employs approximately over 1,000 workers in its evaluator force. The fundamental office is located in Oak Brook Terrace, Illinois. Organization structure. Its organization structure functions on globally improving patient safety as well as quality of health care. It helps an organization to provide a service to the public by creating standards of practice and evaluating and inspecting organizations have risen to meet them. Analyze the impact the agency or body has on quality at each level of health care. Healthcare organization. The Joint Commission accredited medical organizations are required to routinely review their process in various departments and sections. As a result, multiple studies have proven that accreditation by the Joint Commission results in better quality of care in healthcare facilities and even enhanced patient outcomes for certain specialty areas. The Public Health Accreditation Board conducted a survey where 98% of the patients confirmed that upon accreditation by the Joint Commission, enhanced the quality and performance of their health organization. Accreditation programs should be maintained as an instrument and means of improving and developing the quality of healthcare service. Upon accreditation, the quality of health, the quality of care and performance of health organization is enhanced, as well as the level of trust in the organization is proven to go up. This is evidenced by more patients reported to visit health care organizations after they have been accredited by the Joint Commission, which means they are enhanced visits to health care organizations as well as improve performance. Nursing practice. The Joint Commission makes nurses in the accredited healthcare organization become surveyors and reviewers, where it empowers their role and practice in the organization. Also, the reduction of variation in clinical processes and subsequent standardization has resulted in reduced areas being reported in the nursing practice upon accreditation, which enhances the quality of practice. Patient care. Upon accreditation by the Joint Commission, patient care is improved as the variation in the clinical process is reduced. The consistent approach to care that is created by the standardization of clinical procedures has enhanced the quality of patient care as evidenced by the reduced errors in the practice. The Joint Commission has played a very critical role in enhancing the quality of current U.S. healthcare system at different levels, from health organizations, nursing practice, and the level of patient care. The history of Joint Commission is very expansive. The report only covers the oldest portion of it. The Joint Commission also reports quarterly about the quality standards in different healthcare issues and provides review and surveys the healthcare organization every 3 years.